Hello and welcome to Maritime Medicine. In this session, we'll discuss cold illness and injury. By the end of this session, you'll be able to identify risk factors for cold illness, list 4 signs or symptoms of frostbite, list the symptoms, signs, prevention, and treatment of trench foot or immersion foot, list 5 signs and symptoms of hypothermia, identify the 3 stages of hypothermia by signs and symptoms, ability to self-rewarm, and their predicted temperature, and treat a patient with mild, moderate, and severe hypothermia. The human body is amazing in its ability to maintain a very narrow range of core body temperature in the face of tremendous environmental variation. So we manage to maintain a core body temperature in a range of between 95 degrees Fahrenheit and 100.7 degrees Fahrenheit, or 35 to 38 degrees Celsius, which is really the optimal metabolic functional range for us. And we do this through a process called homeostasis, which is a balance of thermal inputs and drains on the body and the body's ability to generate heat or to lose heat as needed, depending on hot or cold stress. We lose heat to the environment in a number of ways. The most important of this is loss through infrared radiation. As a warm body, we radiate infrared radiation out to colder bodies and colder objects. That's about 40% of our total heat loss. Despite many experiments and designs to try to decrease this infrared radiation heat loss, there haven't been a lot of great successes in the management of cold illness. And so it's something that we expect but can't really control. The heat flows from the hotter body to the colder body via infrared radiation. And it's the same reason why you can use a set of infrared goggles and see a human being. You're seeing their heat loss to the environment. Evaporation is a very important mechanism of heat loss in hot environments that unfortunately is just as effective in cold environments at taking away heat from the human body. So in a hot environment or in a cold environment where we work too much, we sweat, and we basically put a film of water on our skin. As that evaporates, we lose 575 calories per ml. Now that's 575 calories, not kcals, so you can't sweat away a cheeseburger pretty easily. But we do lose a fair amount of heat for such a relatively simple process. And again, in a hot environment, we're going to sweat to lose heat. In a cold environment, when we get wet, this evaporation will take away just as much heat. Conduction is a major source of heat loss, and it's a big problem for a casualty who's immobile or entrapped or unresponsive. Anywhere there's direct contact of an uninsulated surface of your casualty against a colder object, heat will flow from the casualty into that colder object. And so the more of the casualty in contact with that object, the greater the heat loss. Conversely, if you can insulate them from that colder object, you can eliminate conduction heat loss. Convection is another problem. We generate a microenvironment around ourselves that's trapped around us by our body hair, and by our clothing, and when we're in the water, those hold water in place. When we're not in the water, that holds air in place, and we warm and humidify that air. And as we heat it, it tends to want to rise, and so that creates microcurrents, and the same is true of water around us, and that carries away heat, and this is augmented by wind and actually can work with evaporation as well to result in fairly significant heat loss. So our body obviously needs to be able to protect us from heat loss. If a normal core temperature is 37 degrees Celsius, just sort of in the mid-range, then humans for the most part live in environments that are far below our normal core body temperature. So we have to be pretty darn good at protecting ourselves from heat loss. And we do that through 2 ways. The first is a behavioral imperative. When you feel cold and want to put on another sweater or go somewhere warm, that's not just a conscious decision. That's a preconscious behavioral imperative to warm up, and it gets translated to a conscious decision. So if you want to get warm, it's because your body wants you to get warm. We also can generate heat, thermogenesis, and we do that through muscular activity. And we can do that through useful muscular activity. So you're out hiking, you're starting to feel a bit cool. You could sit around and shiver, which is useless muscular activity, or you could put up the tent, collect some firewood, and set up camp, which is useful muscular activity, which will generate just as much heat. So we use our muscles either to do useful work, which generates heat as a byproduct, or to do useless work, sit and shiver, to generate heat as the primary objective. We also narrow down our blood vessels peripherally. We get peripheral vasoconstriction. And what peripheral vasoconstriction does is it decreases blood flow to our larger surface area to volume ratio appendages, that is, our arms and our legs. So we decrease blood flow to high surface area parts of our body, and that decreases our heat loss as well, since the blood is carrying the warmth, the heat that's generated in our core from a lot of our metabolic processes. Cold illnesses and injuries are very common shipboard events. If you think about contributing factors and you think about a shipboard environment, you can see why they're so common. If the environment's cold, you're at risk for a cold injury or illness. Wet, it's always wet shipboard. Anytime there's wind, you increase issues with convection, conduction, and evaporation. You ever work hard enough shipboard to sweat? Well, if you do that in the cold, you're going to lose heat as well. Chronic illnesses, particularly certain medications taken for chronic illnesses like for heart disease or antihypertensives for high blood pressure or medications that are used for behavioral health issues, are all contributors to cold illness and injury. Drugs and alcohol can contribute. Dehydration, that never happens shipboard. And lack of sleep, well, everybody gets plenty of sleep. Lack of food, that's less of a problem, but if you don't allow yourself access to food, to caloric intake so that your body has fuel to produce heat, you're going to get into trouble. And then injuries or immobility also increase your risk of cold illness and injury. We've recognized for quite some time that the cold can be devastating on the human body. And although I won't go through each of these examples, cold injuries, particularly frostbite, trench foot or immersion foot, are huge issues for people in a cold environment. In the Falklands War, there were 200 Argentinian combat deaths, more or less, and 200 Argentinian amputations related to cold injury. Well, let's start by talking about frostnip. And this is very mild cutaneous cooling. You can form some ice crystals on the superficial most skin, but it's not really tissue freezing. It's in areas of high exposure, like your fingers or toes or your ears, the tip of your nose, that will tend to cool faster than anywhere else. The blood supply is a little less robust than more proximally. This is typically painless, and the patient may push on their nose and say, I don't really feel my nose and it feels a little firm, and then you push on it and say, yep, you look like you've got some frostnip there. This can easily be prevented by keeping the vulnerable parts covered and warm. A little harder on the nose, although a good face mask will certainly keep your nose warm. And to warm them up, you have them cover the cold parts and warm those. Don't rub them, but cover them up. And then systemic rewarming. So nice cup of hot cocoa. If they're starting to decrease their core body temperature, they're going to be at increased risk for frostnip. So just make sure their core body temperature is where it should be. In frostbite, you get an actual freezing injury to the soft tissues. And this is actually a two-part problem. The problem relates to the fact that the local environment, the feet, the hands, whatever's getting frostbitten, is cold. It's cold there. It's freezing. It's below 32 Fahrenheit or 0 Celsius, so actual water freezing can occur. But this typically won't happen if the body's able to deliver sufficient warm blood to the extremities. Penguins' feet don't freeze on the ice. They have a countercurrent mechanism that actually is designed to keep their feet warm. Your body's pretty reasonable in its ability to keep your feet and your hands warm as well, But if you can't generate enough heat, if you're becoming systemically hypothermic, or you've got an issue with blood delivery to your extremities, you've got overly tight clothes or constricting clothes or bands on, or you're dehydrated so you don't have as much blood volume, that can result in frostbite. And what happens, you develop extracellular ice crystals. You only get intracellular ice crystals if you have very rapid freezing. So for the most part, these are the fluids around the cells that freeze. They change the solutes, the salts in the local water, so that can cause damage to the cells. There are other issues as well, physical expansion in those areas, and you basically cut off blood supply. But these frostbitten areas can completely recover. Those tissues are not metabolically active when they're that cold. They're in a metabolic ice box. So with proper rewarming, they should be able to heal without a problem. They should be able to heal and fully recover. So we classify frostbite injuries based on what we find on our exam. And so this also tells you what the patient's presentation is. We'll start by saying that these are usually numb and painless extremities as they're freezing. And so victims of frostbite may not realize it's occurring. One of your responsibilities is to recognize environmental conditions in which frostbite could occur and monitor the crew and make sure that the crew is self-monitoring and understands their risk. So in first degree frostbite, and there are a lot of classification systems, but none of them are really great, and so this is a fairly easy one to use that's almost universally recognized. In first degree frostbite, you have numbness, you can get some redness, so if you look at the great toe on this foot, it's a little bit red. You can get white or yellow plaques, you don't really see any here, and there's some edema, but there's no real tissue loss. In second degree, you can get those findings of the first degree, as well as blisters. So on that second toe there, you can see a large blister, and it's surrounded by some redness. In a third degree, that blister will fill with blood. And so there's hemorrhage into it, which shows more extensive damage. And in fourth degree, you're actually freezing the tissues underneath the skin, and that can be very hard to differentiate because a frozen skin will feel hard like a block of wood, and you don't know if they've frozen all the way to the bone or not. So that's going to be very difficult to differentiate in the field. So if you stick to first, second, and third degree in describing what you're finding, the second and third degree, you have a hard woody foot or hard woody tissue that's frozen. In the first degree, there's still some pliability. Now the key to managing frostbite is to prevent it in the first place. So we do that by preventing systemic hypothermia. So the individuals need to keep themselves warm, protect themselves from the risk factors that would make them hypothermic, be aware when they're starting to get hypothermic. You want to prevent hypovolemia, so keep well hydrated, good urine output, make sure that there's plenty of circulating volume. Avoid over-tight clothes or constricting bands, particularly the too many socks syndrome. So you'll get someone whose feet tend to get cold, and they'll put on 4 or 5 layers of socks thinking that that's going to insulate the foot. Well, the insulation from socks and footwear actually comes from the air that's trapped around the sock or in the insulating material of the footwear. And when you put on multiple socks, you actually get rid of that airspace when you cram it in, and by conduction, you can essentially get conduction of cold from the outside environment straight through to the foot because there's no insulating airspace. And remain active. The more you're immobilized, the less you have blood flow to your at-risk soft tissues, and the less heat you're generating. So the treatment of frostbite starts with the treatment of systemic hypothermia. The patient needs to have a core body temperature above 93 degrees Fahrenheit or 34 degrees Celsius so they can have no more than very mild hypothermia. Remove any constricting items, rings, watches, overly tight clothes, bracelets, etc., and immerse the frozen part in a warm water bath. This is not full body immersion, this is just the frozen part. Warm water, 100 to 110 degrees Fahrenheit or 37 to 42 degrees Celsius, and maintain the bath temperature. So you pour the bath without the frozen part in it. You check the temperature. You make sure it's all properly mixed. There's not hot water surrounded by eddies of cold water. So it's thoroughly mixed. Then you immerse the frozen part. And you continue to monitor the temperature of the bath, because that frozen part is going to be a heat sink. So it's like putting a giant block of ice into a punch bowl. It's going to cool down the water. So you monitor the temperature. When the temperature hits 100 degrees Fahrenheit, remove the frozen part, rewarm the bath. Don't pour hot water into the bath while the frozen part is in the bath. One of the worst things that you can do for a patient with frostbite is to burn the frozen part. That makes the outcome so much worse, and that can happen when you pour hot water in. That can also happen if you try to rewarm the patient near an open flame. So don't rewarm near an open flame, because they're insensate. They have no sense. They can't feel anything in that frozen body part, and so it's very easy to burn it. And once you burn it, management becomes a nightmare. Also, don't massage the injured part. The ice crystals can do more damage. And never rub snow against a frostbitten part. That will cause both external and internal damage. Also, don't thaw a part that'll be refrozen. And how quickly it'll be refrozen, I can't say. There's no clear consensus on what that means. But generally, we say this when we're talking about someone who is going to be evacuated, and you make a decision: do I rewarm the part or do I not rewarm the part? And if the evacuation means that they're going to refreeze, you don't rewarm it. Although, frankly, evacuating, typically they rewarm their own body parts slowly just by the physical activity. If it isn't going to refreeze as part of the evacuation, then you go ahead and you rewarm it. I would say that shipboard, where you're going to be able to control the patient's exposure, just rewarm it. If you've abandoned ship and you have a frozen body part, leave it frozen, because you really can't guarantee that it's not going to continuously refreeze, and if it does, that causes significant injury. The other thing is, if somebody froze their foot and then they came in from working, they walked around for a while and it started to warm up, so it's partially unfrozen, what do you do with it? Well, you won't hurt it if it's already thawed by continuing to rewarm it. On the other hand, if you fail to rewarm it, that prolonged freezing could cause further injury if it's something that you could have treated. So always err on the side of rewarming, and if you have any question, just rewarm the part. Now, rewarming is incredibly painful. So you're going to treat their pain, and you're going to use a combined approach to doing that. You'll use antithromboxane agents like non-steroidal anti-inflammatories, that is ibuprofen, and that actually helps with the healing process, not just pain control, although there is also some pain control. You will probably also need to use narcotics to achieve sufficient pain control, so morphine, possibly oral tramadol or a hydrocodone product. And post-rewarming, make sure their tetanus immunization is up to date, and exercise strict wound care. Treat these like open wounds. Put sterile dressings between the digits so that they don't adhere to each other. If there's any sign of infection, put them on antibiotics. And if they've got other injuries, they had severe hypothermia, there's anything else going on, evacuate them. Otherwise, this is something that you should be able to manage on your own. And if you look at these pictures, the top picture is the original freezing injury immediately after the event. The second picture down is about 2 weeks after, and then the third picture down is about 3 weeks after. And you can see how there's involvement of the third toe, which you really don't even see on the first picture particularly. There's maybe a little bit of yellow placking on it, but that could frankly just be the way their skin is, if it's thickened and calloused. And you can see a little bit of bleeding underneath the toenail of the great toe, and you see how bright red that second picture is, and that's starting to heal by the third picture. The general recommendation is nobody does anything like surgery or debridement or amputation for these things until the injury has completely declared itself. That is, the dead parts are clearly dead and the healthy parts are clearly healthy, and that's typically up to 6 months. So there is no rush to do anything other than good wound management for these. Immersion foot is something that you'll have plenty of opportunity to be exposed to, particularly if you're on a sailing vessel. It's a non-freezing local cold injury. So you have this subacute or chronic exposure to cold above 32 Fahrenheit or 0 Celsius. So the tissue isn't freezing, but it's persistently cold. And in a wet environment like shipboard, this can occur in as little as 24 hours. Typically on land, it takes 4 to 5 days of continuous exposure to see immersion or trench foot. The mechanism of injury is moisture-induced maceration, so the feet are wet and wet tissue begins to break down. You also have cold-induced vasoconstriction, so you get very poor blood flow to those tissues, so that results in further damage, and that can be prolonged. You get vasomotor instability. The vessels can't decide whether they're constricted or dilated, and so you get even more damage. And typically there's excessively tight footwear, or again, too many sock syndrome, where people have multiple layers of socks on and are constricting the foot, and immobility. This is a disease both of people who are standing in moist environments for a long time, in a trench in warfare, which is where trench foot comes from, or in the landside environment. We often see this in the homeless and chronic inebriates who are immobile and exposed to cold but non-freezing temperatures. So on presentation, the limbs will be white or yellowish white over the area of injury. There'll be some local swelling. The tissue will be broken down and macerated, which basically looks like it's scaling apart, and it's painless when it's in this state. There's anesthesia over the foot, which is a real blessing because what follows is not painless. This can typically be prevented by changing into clean, dry socks up to several times a day, depending on how often you're immersing the feet, at least once a day, preferably several times a day if you're constantly immersed in water. You need to have dry feet periods, so times when your feet can be completely dry and not be exposed to this ongoing moisture, and try to prevent hypothermia, because systemic hypothermia will contribute to decreased blood flow to the feet and make the situation worse. Treatment is to remove the wet garments, dry and elevate the feet, and keep bedclothes from resting on the feet because they can make the maceration worse and are very, very uncomfortable. These people, as they rewarm, get what's called hyperesthesia, so a really overactive sensitivity to even light touch is extremely painful. You want to restore normothermia, so the patient himself systemically is not hypothermic. Now, you don't actually need to do local tissue rewarming because the tissue is not frozen. And in fact, there have been some studies that show that if you cool it with a fan, cool the feet with a fan while the patient is systemically rewarming, so the rest of them is bundled up and they're eating and they're drinking warm things, you actually can decrease the pain, the swelling, and the blistering of the feet. So something to keep in mind for treating these. As you treat, they go into what's called the hyperemic phase, so high blood flow, the feet turn red. This can last hours to weeks. They get a lot of vasomotor instability of the blood vessels, so the blood vessels dilate and constrict and dilate and constrict, and the feet become red hot and swollen and just are incredibly painful. And in more severe cases, they'll get blisters all over the feet, and in the most severe cases, they get gangrene in those areas. So this can be a very significant injury. If you recall the picture that we saw at the start of this, the patient had lost half of their foot from the gangrene. In the post-hyperemic phase, so once that has resolved, they may have no symptoms at all. Once they're healed, they're fine. That happens in mild cases. But in more severe cases, they can have symptoms that last essentially a lifetime of ongoing symptoms of coolness and alternate paleness and then redness and flushing of the extremity. And oddly enough, on exertion, they may get recurrent blistering, swelling, and numbness and tingling in the foot. So if someone's had significant, severe trench foot, that may be their long-term prognosis. So now let's talk about hypothermia. Hypothermia is the body-wide cooling, and it's defined clinically as a core body temperature below 95 Fahrenheit or 35 degrees Celsius. Now, it's really hard to accurately measure core body temperature in the hospital environment, let alone in the out-of-hospital environment. So you're going to measure a temperature. You're probably going to measure a rectal temperature. You're going to need a low-reading thermometer, either a medical thermometer specifically designed for low reading or an indoor-outdoor thermometer that gives you continuous reading. But what's much more important to you are their symptoms, the signs that you find, and the trend in their core body temperature. So people can be hypothermic because of intrinsic reasons. That is, they get septic, they have low thyroid, there's a problem with their metabolism, so they're unable to generate heat. Or there can be extrinsic factors, which is what we're talking about here. The environment is cold. And that leads us to a really practical physiologic definition. When you've got cold stress that exceeds the body's ability to maintain a normal body temperature. So whether that's because the patient is ill and can't maintain it, and that could be a very mild cold stress, a temperature of 80 degrees, or it could be because you have extreme cold stress in an otherwise healthy person. This is multi-system disease. It's not just the skin that's cold. This affects everything. The contributing factors are the same as for all the other cold illness and all the other cold injuries. That cold environment, the wet environment with wind, healthy people sweating while you're working is a huge problem. Dehydration, poor sleep, all of those things contribute to hypothermia, particularly not eating, not drinking enough fluid. So the presentation depends on the core body temperature, but the core body temperature is not an absolute correlation to the patient's clinical state. There have been patients with temperatures in the 80s who've been able to drive themselves to a hospital. And so you really need to look at their clinical presentation. And then from your practical perspective, you need to be able to answer the question, are they going to be able to self-rewarm, or am I going to need to do something for them? And based on that, you can predict their likely core body temperature. So for a patient with mild hypothermia, they initially lose fine motor function, then gross motor function. They become less able to think, and they can develop some confusion. So they're cold, they feel cold, they know they're getting cold, they're shivering, so their body is trying to generate heat, and they've got the beginning of the umbles. They fumble with things, they stumble and trip, they tumble and fall, they mumble, they grumble to themselves. And typically, they're able to self-rewarm. If you remove them from cold stress and you give them something to eat or drink, they're going to be able to rewarm. They're still shivering, so they still have the ability to generate heat. And you can predict their temperature is in the 90 to 95 Fahrenheit or 32 to 35 Celsius range. In moderate hypothermia, they stop shivering, so they now have lost that mechanism of self-rewarming. The heart becomes vulnerable to an irregular heartbeat called atrial fibrillation, where the top part of the heart, the atria, just sit and shake instead of squeezing in a coordinated fashion. And as they get colder, they'll be confused and ultimately become unconscious. So as soon as they lose their ability to shiver, they really can't rewarm. And that's really at the transition from mild to moderate hypothermia. You can predict their core temperature will be somewhere between 80 to 90 Fahrenheit or 28 to 32 Celsius. In severe hypothermia, they look dead. The heart is very vulnerable to going into an irregular rhythm where the lower part of the heart just sits and quivers, called ventricular fibrillation. That can happen with rough handling. The colder they get, the more likely that will happen on its own. These patients are unresponsive. The muscles can be rigid. You may not be able to detect any vital signs. and they don't have any ability to self-rewarm. If they're going to be warmed, it's all going to be active warming, and their core body temperature is below 82 Fahrenheit or 28 Celsius. It's critical to prevent hypothermia, not just because you don't want hypothermia to progress through mild to moderate and severe, but because the chances of the individual injuring themselves or making an error, even with mild hypothermia, are much higher than if they're normothermic. So you don't want that to happen as a consequence of the hypothermia. So you need to recognize when there's cold stress. You need to make sure people are eating and drinking, getting enough in so their body can be metabolically active. People need to wear protective clothing that's wicking on the inner layer, pull moisture and sweat away, warm in the middle layer, and if they're going to be in wind, windproof to minimize the impact of evaporation. Although, honestly, if they're not going to be in a lot of wind, windproof can be problematic because it often traps moisture on the second layer. So you need to find that balance. And you need to make sure the protective clothing is not too tight, that it restricts blood flow and puts them at risk for things like immersion foot or frostbite. Don't let people to work till they sweat. People need to work until they're feeling warm and then stop and take a break. And this involves oftentimes taking off layers when you begin working and then putting them back on when you finish working to maintain a good clothing environment without inducing sweating. Reheat when you have the chance. So if you're finishing outside work and you can go inside to a heater and rewarm yourself, do that. And avoid alcohol when you're in cold environments. The treatment for mild hypothermia is to eliminate the cold stress. So remove them from the cold environment. If their clothes are wet, get them into warm, dry clothes, and then promote self-rewarming. So warm, sweet drinks, that gets them some warmth, that gets them some liquid, that gets them some calories. Give them food, and consider having them exercise. Do something useful with all that muscle activity to generate some excess heat. And evacuation is typically unnecessary unless there's some other concomitant injury, something else going on. In moderate hypothermia, again, you need to eliminate the cold stress or remove them from the environment, put them in warm, dry clothes, and you'll need to actively rewarm them. Now, if it's only slightly into moderate hypothermia, you may be able to get them back to a point where they can self-rewarm fairly easily. But if it's anything more than very mild, moderate hypothermia, then you're going to need to be very aggressive in actively rewarming. So heated IV fluids, hot packs at a minimum on the neck and in the groin. You can put them into the armpits, the axilla as well, although that tends to cause a little bit more peripheral rewarming than the other locations. But make sure your hot packs are wrapped in something to protect them from burning the patient. And be creative. If you don't have hot packs, put warm water into a water bottle, or heat up potatoes in a microwave or in the oven and use those in place of hot packs. Those are all options for you. And rescue to patient skin-to-skin contact is also a possibility. Doesn't tend to be really effective, but it's not bad. And if you don't have any other rewarming sources that works, shipboard, you should have plenty of other ways to rewarm your patient. And if you've properly planned on how you're going to rewarm these patients and you're able to continuously monitor them, then you probably won't need to evacuate them. But if you really haven't planned this through and you don't have good mechanism for rewarming and you really can't monitor them, talk to medical control. So the treatment for severe hypothermia is the same as the treatment for moderate hypothermia, but you need to be much more aggressive with your active reheating. So if you have a 600 watt or an 850 watt heater that blows hot air, and you've got a soft rewarming blanket that's designed to hook up to that, or you build a rigid torso cover out of insulated wood panels or fiberboard panels, those are very effective for reheating patients. Unfortunately, most people don't have this around. If you do have a source of warm air, not hot, You don't want to burn these patients. You can use that, and it's okay to use it even if they have frostbite. It won't desiccate or mummify the frostbite, but you just need to make sure that it's not so hot that it's going to burn them, because their ability to sense heat and pain is pretty low. What's much more likely to be available if you use a little foresight and buy these are a charcoal vest, forced hot air heater. These are little units that burn charcoal briquette and blow hot air out. They're fairly cheap. I think there's only one on the market right now, but these are easy to use. They've been studied and proven to be effective in actively rewarming patients in the pre-hospital environment, in the out-of-hospital environment. So it's worth looking into one of those. The only brand I know of is Heat Pack, HEATPAC. There may be others available, but look into those. Remember that these patients are at very high risk for sudden cardiac arrest. Their heart, particularly the lower part of the heart, the ventricles, is very sensitive when it's cold. We call irritable. So don't drop them or jar them or bump them or manhandle the patient. Don't flip them around to take off their wet clothes. Move them as little as possible to get them into a safe environment, and then reheat them in place. And talk about evacuation with medical control. If you can completely rewarm them and they return to their baseline and you can keep them from getting hypothermic again, it may be safer not to evacuate them, but that's not a decision for you to make. That's a decision to be made by medical control and speaking with the master and just thinking this process through. Do not immerse them in warm water. Full body immersion for hypothermia, as much as it seems like it would be a good idea, increases mortality. Every study that's looked at this has shown that people tend to die because they get something called afterdrop. And in afterdrop, you continue to drop your core body temperature after you start the rewarming process. And it's probably multifactorial, but thought to be at least in part due to return of cold water from the extremities to the core. And so your core warms up, so your body stops using all of its heat conservation methods, and you start to peripherally vasodilate, and all this cold blood that's been sitting out in the periphery starts to flow back in. And if you warm up the periphery too quickly, you can dump that cold blood back into the core much more quickly, and so that's something to be avoided. Now, you will have hypothermic patients who look like they're dead. In severe hypothermia, you can listen for breathing for a minute or two and you may not detect any. It's so shallow. You may not be able to sense a pulse rate at all. There are people who are hypothermic and they're going to stay dead. So somebody with a core body temperature of less than 50 Fahrenheit or 10 Celsius is dead and will not get better. Anyone who's been submersed for greater than an hour in any temperature water who has no vital signs is dead and will not get better. Anyone with obvious fatal injuries, so if you're decapitated or you have a hemicorpectomy, half your body is gone, doesn't matter what your core body temperature is, you're dead. And anyone who's frozen, so their chest is frozen in place and you can't compress it, or they have ice in their airway, they're dead. Talk to medical control. They do not need to be resuscitated. Everyone else needs to be resuscitated, and you're going to warm them in place. Trying to arrange evacuation is going to be important, but your key is to rewarm them in place. And this is because the recommendations about CPR and resuscitation in hypothermic patients aren't based on phenomenal evidence. It's mostly based on experience and case series, but not good studies. And so the best recommendation out there seems to be that if you can get a hypothermic patient without vital signs to a facility where they can do cardiopulmonary bypass rewarming within 3 hours, then withhold CPR. Otherwise, do CPR, rewarm them in place, and get them to a core body temperature of greater than 90 Fahrenheit or 32 Celsius, and make a decision at that point based on whether or not they have return of vital signs. And it's going to be very difficult for you to make arrangements to get someone to an appropriate facility within 3 hours. So talk to medical control, but and arrange evacuation, because if you resuscitate them, they need to be evacuated. But your goal should be to do CPR, to rewarm them in place, and if you get them up to a normal body temperature and they're still in cardiac arrest, then talk to medical control about the possibility of terminating resuscitation. Please complete any associated knowledge reviews, and if you have any questions, don't hesitate to contact your instructor or professor. Thank you very much.